So I'm going to talk about the current state of medicinal cannabis in Australia, and start off with a quote from Charles Dickens that's very well known. It was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolhardiness. Some of you may know that just in this last week, our Prime Minister Tony Abbott said that 2014 was the year of achievement. And I don't know whether he was talking about drug law reform in Australia, but certainly 2014 was the best year we've ever had. He seems to think it was the best year that Australia's ever had, but certainly it was a good year for drug law reform. The case I'm going to be presenting to you today is really to argue that the best way to speed up law reform for the drugs that many in this room are interested, the entheogens, is to speed up other drug law reforms. I think this is going to be a sequential process, and I think the entheogens, whether you like it or not, are going to be at the end of a long queue. Anyway, more about that later. So I'm going to talk a little bit about political support for medicinal cannabis, community support, say something about expert opinion, summarize that, talk about some current diversions, which are quite significant, where we go from here, relationships of the issue of medicinal cannabis to other drug law reforms, and then some concluding remarks. Now, we've got some quite significant political support for drug law, for medicinal cannabis in Australia. Prime Minister Tony Abbott, much to everybody's surprise, came out in support for medicinal cannabis. The New South Wales Premier, Bob Carr, had come out for medicinal cannabis in 2003, but he was rolled by his party. That hasn't been said openly, but let's face it, that's what must have happened. And the same thing happened with the current New South Wales Liberal Premier, Mike Baird, this year in 2014. He was also rolled by his party. He wanted to proceed to medicinal cannabis, they stopped him. Seems like the new Victorian Premier might be interested in pursuing this issue, let's hope so. Tasmanian government, we're getting opposing signals from them. ACT government, a bit warmer, but so far the support has been for research, not routine use of a medicine under certain conditions. And so far, most of the support seems to have been for pharmaceutical agents, not botanical cannabis. And the reasons, I think, why pharmaceutical agents, existing pharmaceutical agents, are problematic. I'll talk about that in a moment. And right now we've got private members' bills in the Federal Senate and also before the New South Wales Parliament. Never had that before. So things are looking good in a way, but I would argue that we've never been in as strong a position for medicinal cannabis in Australia as we are right now. So that's a positive. And we have very strong community support, and that's been the case for a long while. We had 69% support from the community in a very large sample conducted by the, those initials stand for the National Drug Strategy Household Survey, both in their 2010 survey published the following year and in the 2013 survey published in the last couple of weeks. We had 74% support for medicinal cannabis research in both of those surveys, 2010, 2013. And we had 66% support for medicinal cannabis in the July 2014 ReachTel survey. Very large sample, and very significantly, that survey had a majority of voters for the Liberal National Party, for the Labor Party, for the Greens, and for the Palmer United Party, or Palmer Disunited Party, I suppose it should now be. And also there were majorities among men, women, and among all the four age groups. So very strong community support. But significantly, expert medical opinion is divided. Whether they should be or shouldn't be, fact is they are divided. One group says the evidence is weak, that the risks are unacceptably high, especially schizophrenia and other forms of mental illness, that conventional medicines rarely fail, and if needed, we could use, reluctantly, we could use cannabinoid pharmaceuticals. The second group, and I'm certainly in the second group, say the evidence for efficacy is strong. Also for safety, argues that we have over 100 randomized controlled trials have been published, and the overwhelming majority of those are very favorable. The risks are minimal, especially when you look at studies of medicinal cannabis rather than studies of recreational cannabis, which is what opponents tend to quote the latter literature rather than the former literature. These experts also argue that conventional medicines fail far too often, and that cannabinoid pharmaceuticals are very problematic. I'll say more about that later. Then we've got a third group who say, no, it's a natural herb, we don't need any evidence, there are no risks, conventional medicines are dangerous, pharmaceutical companies can't be trusted, certainly agree with that, and everybody's got a right to use. And I think a lot of this really needs more debate. But the key point I want to make to you is that governments rarely move when key expert opinions are seriously divided. That's not something that gets said out loud in public, but I can tell you that that's something that really happens. That a major problem holding this up is the division among experts, medical experts. Law and law enforcement are also divided. We have the commander of the police in Tamworth in northern New South Wales who said he wouldn't charge a family that's using medicinal cannabis, and I'm pleased he made that decision, but he would order his own troops, his own police, not to charge this family using medicinal cannabis or any other families using medicinal cannabis. But police in other parts of the country have had no such qualms, and they have gone ahead and charged families, and they've also reported those families to government departments, resulting in potential loss of children to authorities. So some very serious divisions among police, and we recently had a case in October in Port Macquarie in New South Wales, Tony Bowers, where the judge upheld an appeal against a sentence where the offender, so-called, had pleaded guilty and had been found guilty by the court, and a previous prison sentence had been changed by this judge on appeal to a 12 months good behaviour, a 6 months good behaviour bond. So in summary, to quote a famous quote by Gramsci, the old is dead, but the new is not yet born. The politicians are declining to support the status quo, but there's not enough of them willing to support a change to a new regime. Strong support in the community and also amongst the media for medicinal cannabis and also for more research on medicinal cannabis. And research on medicinal cannabis is great. We certainly need more of that. We hardly do any in Australia, but it's not the primary need. The primary need, I believe, is to get on and start treating people. The division among law and law enforcement is very troubling. The fact that the laws are being enforced in some parts of the country, not being enforced in other parts of the country. And the division among medical experts is really quite a serious problem for us. And another serious problem that doesn't get talked about is the real dilemma that exists around childhood epilepsy and treatment with cannabis. And the problem here is that there's a lot of anecdote about this. Hard to ignore that. It's heart-moving, it's very heart-rending stuff. But anecdote is powerful, but it's not really rigorous science. And as of today, there are still no rigorous published studies on medicinal cannabis used in young children with epilepsy. So it's very difficult in the age of evidence-based medicine to know what the hell we should do there. What we've got at the moment, what's accepted is unregulated medicinal cannabis, pharmaceuticals and research. In my view, that's a terrible situation to be in. Let's hope in 2015 we get a bit further than that. And I think the support for research with medicinal cannabis is being used as a diversion. The politicians don't know how to thread this issue through the political maze to actually provide medicinal cannabis, so they're supporting research as a kind of distraction. And they're supporting nabiximols, which is the generic name for product which uses the trade name Sativex. Now, Sativex has got some definite pluses, but it's got some significant negatives. And the pluses are that it's already registered by the Therapeutic Goods Administration in Australia, but it's only registered for one condition. The second plus is that it contains a broad spectrum of cannabinoids rather than just one or two. But you have to have spasticity due to multiple sclerosis, you have to satisfy stringent criteria, and even then your doctor is only allowed to prescribe it to you for a short period and has to apply again. It's available in Australia in theory, but it's not available in practice. And most importantly of all, it costs about $500 a month. We have to remember that most of the people who would want to use medicinal cannabis in Australia are people who would have been ill for a while or would be elderly, and they are likely to have very limited savings and to have largely eroded those savings. So $500 a month really means that it's unaffordable for most people who would want to use it. And I can't see our current federal government or any of the state governments rushing up to subsidise that. It's unlikely that that price would come down for many, many years because the high price is covering a short patent period during which the company would want to recoup its very considerable costs of development. It's also important to recognise that the older cannabis pharmaceuticals failed, and they failed for reasons of the pharmacology of cannabis, which is very unusual. Don't have time to go into that now, but they really did fail. They had very little penetration in the market. I've already mentioned this about medicinal cannabis for epilepsy, so I'll move on. Now, one of the things that's never talked about, God knows why, in this issue is the huge publication bias against medicinal cannabis. It's not talked about by the supporters of medicinal cannabis or the opponents of medicinal cannabis, but it's really one of the huge problems that we face when we're talking about this issue. Publication bias refers to the fact that in most countries, research is seriously obstructed by major legal and funding obstacles. Hard to impossible to get funding, likewise to get ethical approval, and likewise to get the actual substance that you need to study. So publication bias really means that very little research gets done. We have on the one hand a situation where research to identify the harms from recreational cannabis are generously funded and readily approved, but the funds for, but approval for medicinal cannabis is the exact opposite. And this publication bias is really a very powerful force in this whole debate, never spoken about. Here's a quote from Shirley Simpson, who was the spokeswoman for the National Institute on Drug Abuse, an arm of the US government. And it's, for those who don't know, this organization funds more than 80% of the illicit drugs research carried out in the world. 80% of the illicit drugs research carried out in the world. She said, quoted in the New York Times in 2010, that the National Institute on Drug Abuse, our focus is primarily on the negative consequences of marijuana use. We generally do not fund research focused on the potential medicinal benefits, beneficial effects of marijuana. So there you have it, a scientific organization that's carrying out a political mission. Despite that, marijuana is now used medicinally in 23 out of the 50 states of the United States of America, plus the District of Columbia, Washington. But the US federal government, despite that, the US federal government still classifies marijuana as Schedule 1. And this means that firstly, it's got considered to have a high potential for abuse. Secondly, no currently accepted medical use in treatment. And thirdly, that it's unsafe even when medically supervised. That's what Schedule 1 means. And this means that officially in the United States, medicinal cannabis is considered to be more dangerous than cocaine, which is in Schedule 2. I mean, it's laughable, but this is this is what we're dealing with. Now, bad enough, but US attitudes influence every other country in the world, including this one. So this publication bias is really quite a serious aspect of this difficult problem. But despite this publication bias, sufficient research has somehow managed to been done around the world of adequate quality, in my view, to justify allowing medicinal cannabis to be approved by regulatory bodies. The number of Medline Index publications has doubled each decade for the last 2 decades, 400 in 1990 and about 1,600 Medline publications in 2010. So there's quite a volume of research that now somehow still gets done. Finally, policy must be based on published research, not the putative results of research which hasn't yet been carried out because of this publication bias. Now, we've also learnt a lot about medicinal cannabis from studies of people who actually use the stuff, regulated or not regulated, including studies that have been done in Australia. And the main use that medicinal cannabis is put to is by people with severe chronic non-cancer pain, things like arthritis. Significantly, in JAMA, the Journal of the American Medical Association, a couple of months ago, a study was reported showing that the opioid overdose death rates in US states that have medicinal cannabis was 25% lower than states that don't have medicinal cannabis. And the longer a state had had medicinal cannabis, the lower the death rate. But that study so far hasn't been replicated. It's only just come out. No doubt other studies like this will soon be published. But this is a very interesting study. If you don't know about it, do read about it. The pressure for more research on medicinal cannabis and for more use of medicinal cannabis is growing internationally. About 20 countries now permit medicinal cannabis, and there are many different regulatory models. Each of the 23 states plus Washington, D.C. have got different ways of handling this, and it's really very hard to work out what are the good and bad aspects of this. And we're now also seeing a connection between this issue and the growing support, at least in the United States, for taxing and regulating recreational cannabis. 2 states approved that, as I'm sure you know, in 2012, and 2 more in just last month in November, plus Washington, D.C. So some movement there. And the research evidence continues to increase. We're also seeing movement in international drug law reform. Somebody mentioned the Global Commission on Drug Policy, and that's had a huge effect since it was first launched in New York in June 2011. And there's no doubt that there is now a global movement for drug law reform. We're seeing that particularly in South America, and what's happened in New Zealand last year has been very encouraging. But we should also remember, and Vendula remarked on this earlier, that the Single Convention from 1961, which is really the first international treaty, there were treaties under the League of Nations, but the first treaty under the UN system, so over 50 years ago, guaranteed not to interfere with medical or scientific use. Nevertheless, if medicinal cannabis is accepted in Australia and other countries, it will be seen as a form of drug law reform. This very significant statement came out by William Brownfield 2 months ago. He's the most senior ranking US government official permitted to talk officially about US government drug policy. And here he is giving a press conference. He's a figure in the US State Department, and in the US system, drug policy, believe it or not, belongs in the State Department, and in the Bureau of International Narcotics and Law Enforcement Affairs, of which William Brownfield is the director. And he's Assistant Secretary status, which means he's 1 slot below John Kerry. And here he is saying, we must have enough flexibility, talking about the international system, to allow us to incorporate changes into practice, to accept the fact that some countries will have very strict drug approaches, other countries will legalize entire categories of drugs. Now, here's the United States trying for over a century to develop a global system of drug prohibition, and inflexible interpretation of the drug treaties was the mantra for all these decades, now turning around in the last few months and saying, no, what we need is a more flexible system. So things are really starting to change. You can argue about how much of a change William Brownfield is actually advocating, but there's no doubt this is a significant development. Now, my view, all drug law reforms are connected to other drug law reforms. It's a system. It's a whole process. It's a sequential process. And I think the head of the queue is recreational cannabis and medicinal cannabis. And they're at the head of the queue because medicinal cannabis is a very difficult issue for politicians, not easy for them to say to suffering people, no, you can't have this drug, even though a lot of senior doctors think you might benefit from it. Difficult issue for them. And recreational cannabis is a growing issue for them also because of the growing support, particularly in the United States, but also in other countries, for reform of recreational cannabis. And then it's also important because the market for cannabis accounts for a very large share of the black market for illicit drugs in economic terms. So there are many reasons why they should be very mindful of cannabis. A lot of their constituents smoke cannabis. A lot of their constituents have smoked cannabis. And of course, it's a gateway drug. If you want to become a US president, you almost have to have smoked cannabis. And I think at the end of the queue are going to be the sort of drugs that we've been talking about today. They have little public health impact, used by a relatively small number of people compared to, say, cannabis. Demand is relatively small, and not many people worry much about them. But things will change as we see this sequential process start moving along. What's the fundamental problem we're dealing with? Well, we're basically trying to fit square pegs into round holes. We've got three different kinds of forces that we're trying to reconcile. We've got a system of international drug treaties, three of them, 1961, 1971, 1988, that 185 countries, roughly, around the world have signed on to, including Australia, including the United States, including New Zealand. So that's one issue. Second issue is the inexorable laws of economics, that if there's strong enough demand, some form of supply always emerges. And the third issue is the unmovable mountain of politics. And for many decades now, bad policy has been wonderful politics. That's now starting to break down, but those three issues somehow have to be reconciled. Another issue that we have to remember is that under prohibition, more dangerous drugs displace less dangerous drugs. And we see many, many examples of that around the world, so-called iron law of prohibition. And under reform, I think it's fair enough to expect that that process will reverse. Some people think medicinal cannabis and drug law reform more generally is inevitable, but I caution you from thinking that. And here's a comment by an African-American abolitionist who devoted his life to the abolition of slavery and who said about powerful vested interests that power concedes nothing without a demand. It never did and it never will. And I think that's absolutely right. If we want to see drug law reform, we're going to have to fight for it. Now, I've mentioned a few times this issue of whole plant cannabis versus pharmaceutical cannabis. And pharmaceutical cannabis is really, if nothing changes, that's what we're going to get in Australia. And there is logic for pharmaceuticals. They're not completely irrational. The logic is that especially after the Renaissance, the pharmaceutical drugs started replacing whole plants, and for logical reasons. The advantage was that you could identify and purify the active ingredient, so you knew what was beneficial. You could measure how much of that you were giving, so you could give the same amount tomorrow as you gave yesterday and today, and you could attribute the benefits and also the side effects just to the most active ingredient. So that was really worked for many, many drugs. But cannabis is very unusual. It's got an extraordinarily complicated pharmacology, which very few people really understand, especially among our busy politicians. It's got many psychoactive ingredients, and their interaction is only partly understood. Another aspect that I think changes everything a lot is that inhalation of cannabis vapor is now the least worst form of administration. All the other forms are much more problematic. Smoking is obviously problematic. How can we seriously advocate for a medicine containing particulate matter to be inhaled into the lung? It's offensive to most doctors, including me, to say that that's a medicine. But now that we have a very excellent alternative, better alternative in terms of inhalation of vapor, I think that problem is overcome. So what can I do sitting here in the audience about all this stuff? Well, there's lots of things you can do. You can write letters to the editor of newspapers, metropolitan, suburban, rural, remote, short, sharp letters, just make 1 point well, don't make 6 points badly. You can ring up talkback radio, you can engage busily in social media, you can write or form delegations to go and see your members of parliament, federal level, state level. You can give talks at Apex and Lions. My advice to you is always try and err on the side of understatement, don't overstate the issues. And of course, you can also join the Australian Drug Law Reform Foundation and join Unharm and work through us. So, summarising then, medicinal cannabis is now available in 20 countries. There's plenty of quality evidence for the effectiveness of medicinal cannabis and for its safety. Support for the status quo for medicinal cannabis is collapsing, but there's not enough support yet for change. The division among medical experts is a serious problem. Not sure how we're going to overcome that. The two private members' bills before parliaments in Australia are now a momentous development in this, but there's still a long way to go. What we used to say, the fat lady hasn't yet got up to sing. Well, the fat person, I think we now would say, hasn't got up to sing. I think that's true. This isn't over till it's over. So we've got a long way to go, and I'm sorry for those of you who really want to see the entheogens get up, but I think you're going to have to wait a long time. Thank you very much.
We do have a few minutes for questions if anybody'd like to come up and sling a couple at the audience. I guess I can kick things off by maybe asking on your comments about the contention that cannabis may involve an altered state of consciousness, as in many ways entheogens do, but the other drugs that you listed on your list is further up the list for drug law reform. For example, amphetamines, cocaine, heroin tend not to involve altered states of consciousness which are uncontrollable by the state, by the community, by the mainstream. Do you have any thoughts about similarities and differences in that case between cannabis, entheogens? And I have to say that I suspect there are broader interests than just entheogens among the audience here, but and then those other compounds which you regard as being further up the scale, possibly because they represent a greater threat in a public health sense.
Well, from a medical perspective, there's been a tradition developed over decades, over longer than that really, of regulating medicines. And we make a lot of mistakes, but the system is generally getting better. Still a lot of problems, but it's generally getting better. And now it's come down to 2.5 criteria. Mechanisms is not one of them. The criteria are, is it effective and is it safe? And increasingly, this is important in Australia, not many other countries, is it cost effective? That's why I say 2.5. Now, mechanisms aren't a consideration, because they're an aspect of this issue that is most arguable. And sometimes we don't really understand what the mechanism for a drug's action is until after we've worked out that it is effective or that it isn't effective. And in any case, we're quite happy, us doctors are very happy using medicines that we haven't got a clue how they work, as long as they damn well work and are safe. So now psychology is different and other disciplines are different. So that's a different cultural perspective, professional perspective. And I think we could be arguing for a long time that cannabis does or doesn't work because it does or doesn't change states of consciousness. But what I'm interested in is, did it help Mrs. Smith?
Hi, just in regards to the best method of ingestion, which you suggested was vaporization. I'm a member of an online forum of about 50,000 people called Cannabis Oil Success Stories, where they're making a very strong, very, very strong extracted oil and taking it orally, usually in like a rice-sized grain, and having a lot of success on there in eliminating and reversing and slowing the growth of cancer. I know it's a bit controversial, but some of the mainstream sites seem to have a lot of the information on there about the cell death and things like that. So I was just wondering, my question's about the best method of ingestion.
Well, cannabis is very fat soluble, and that means that its oral absorption is problematic unless it's presented in an oily, fatty medium. But it also means that in one of the uses for the drug, where it is really very, very useful, that is dealing with people who have not benefited from conventional medicines for dealing with their severe, intractable nausea and vomiting post-cancer chemotherapy. The last thing you would want to do is to say to someone, look, I've got some fatty, greasy stuff that you might want to just swallow to overcome your nausea and vomiting. You can see a problem there. So,
in that case, would you suggest vaporization? But the people with these theories, they seem to think that wouldn't give enough concentration to the body.
The other difficulties with oral absorption of cannabis is that it's very slow, and that means that titrating to get the right dose so that the person doesn't get too little, so their symptoms aren't relieved, or too much, and they get unwanted intoxication, and for older people especially, intoxication's an unwanted side effect.
Yeah,
so that's another problem. And the third problem is that the metabolism of swallowed cannabis is different from the metabolism of inhaled cannabis, in the sense that there is an increased amount of stimulatory cannabinoids and a greater propensity to cause side effects. So there are a lot of problems with any orally administered cannabinoids, and this is the reason why the older pharmaceutical agents had no uptake by the market. So then we've got smoking, and then we've got inhalation of vapor. Now, and the fourth method, of course, is spraying on the inside of the mouth, which is the method used for Sativex. Now, the advantage of inhalation is very quick absorption, which means that for medicinal use, that's perfect, because the person can get the right dose. They don't have too much, they don't have too little.
So you should be able to get, the same amount of saturation of the cannabinoids through vaporization?
Well, you get, the patient gets the right dose. There's been a revolution in pain relief. Those of you who've had an operation in the last 5 or 10 years will probably have been given a little button to press, so-called PCA, patient-controlled analgesia, and that's much better for patients. Patients overwhelmingly prefer to control their own pain relief, and incidentally they have more comfort, or less discomfort I should say, and they use less morphine than when the doctor prescribes it and the nurse dispenses it, injects it. So we get much better outcomes if the patient controls their own dose. And how much they use doesn't really matter. What really matters is that their symptoms are relieved and they don't have more than they wanted to have. And they can do that with inhalation of the vapor. So we've got very efficient, affordable vaporizing equipment these days, and that's what we should be using, and I'm sure that's what we will use increasingly.
Thanks.
Thanks. I think in the interest of time we'll move on, but thanks to Alex for sharing his expertise and knowledge.